Welcome back. We talk about dental extraction. Extraction forceps. These instruments are used for removing the tooth from the alveolar bone. The basic components of dental extraction forceps are the handles, hinge or joint, and beaks. The handles of the extraction forceps. Max. Forceps are held with the palm underneath the forceps so that the beak is directed in a superior direction. Mand. Forceps are held with the palm on top of the forceps so that the beak is pointed down toward the teeth. The handles may be straight or curved. The handles are usually of adequate size so that they can be handled comfortably and deliver sufficient pressure and leverage to remove the required tooth. The handles have a serrated surface to allow a positive grip and prevent slippage. The handles are held differently depending on the position of the tooth to be removed. Hinge. The hinge is merely a mechanism for connecting the handles to the beaks. The hinge transfers and concentrates the force applied to the handles to the beaks. Beaks. The beaks of the extraction forceps are the source of the greatest variation among forceps. The beaks are designed to adapt to the tooth root at the siege. There are beaks designed for single-rooted teeth, 2-rooted teeth, and 3-rooted teeth. The design variation is such that the tips of the beaks will adapt closely to the various root formations, decreasing the chance for root fracture. A final design variation is in the width of the beak. Narrow for incisor, broader for molar teeth. The beaks are angled so that they can be placed parallel to the long axis of the teeth, with the handle in a comfortable position. The beaks of anterior max forceps are parallel to the handles. Max molar forceps are offset in a bayonet fashion to allow the operator to comfortably reach the posterior aspect of the mouth and yet keep the beaks parallel to the long axis of the tooth. Mand forceps is set perpendicular to the handles. Maxillary forceps. The max incisors, canine teeth, and premolar teeth are all considered to be single-rooted teeth. The max molars teeth are 3-rooted teeth with a single palatal root and a buccal bifurcation. Therefore, forceps that are adapted to fit the max molars must have a smooth, concave surface for the palatal root and a beak with a pointed design that will fit into the buccal bifurcation on the buccal beak. This requires that the molar forceps come in pairs, a left and a right. The molar forceps should be offset so that the operator can reach the posterior aspect of the mouth and remain in the correct position. The maxillary incisor teeth are extracted with the upper straight forceps. Upper premolar forceps. Upper molar forceps. Bayonet extraction forceps. Jockey forceps. Maxillary cowhorn forceps. Mandibular forceps. Forceps can be used for single-rooted teeth for incisors, canines, and premolars. Forceps for 2-rooted teeth. For the molars. Extraction forceps. Choose handle for access, comfort, and leverage. Choose beaks for adaptation to tooth. Proper placement, apical seating. Controlled, steady forces. Hold at end of handle for greater lever advantage, more power, more feel. Feel what direction tooth wants to come out and go with it. Extraction forceps. Choose handle for access, comfort, and leverage. Choose beaks for adaptation to tooth. Proper placement, apical seating. Controlled, steady forces. Hold at end of handle for greater lever advantage, more power, more feel. Feel what direction tooth wants to come out and go with it. Patient and surgeon prep. Surgeon. PPE, hair properly tied in position and preferably covered with head cap. Patient. Sterile drape across the patient's chest. Mouth rinse vigorously with antiseptic solution like chlorhexidine MW. Patient positioning. The patient is seated comfortably in the dental chair and the back of the chair adjusted so that the head, neck, and trunk of the patient are at straight line. Roll of opposite hand. Reflect the soft tissues. Stabilizes the head. Supports and stabilize the mandible. Supports the alveolar process. The stability of the teeth in the dental arch depends on 1. Integrity of the alveolar process. 2. Periodontal ligament. 3. Gingival attachment. Extraction of a tooth requires 1. Separation of the soft tissue, attachments of the gingiva, and periodontal ligament. 2. Adequate expansion of the alveolus. Gripping the forceps. The forceps is held in the palm of the hand with the thumb supporting it at the joint. On gripping upper premolars and molars forceps, the concave side of the handles should rest on the palm of the hand. The little finger is placed inside the handles and is used to open the forceps during the application to the tooth. When the tooth is properly gripped, the little finger is placed outside the handles. Common errors in gripping the forceps: placing the index finger inside the handles just below the joint, gripping the upper posterior forceps with the convex side of the handles, resting on the palm of the hand, gripping the forceps too near to the joint. This will decrease the amount of force that can be applied to the tooth. Gripping the forceps too far from the joint. This will decrease the control of the operator over the forceps. Initial forceps placement. The dental forceps is designed to grip the root and never the crown. The tooth should be gripped at or just beyond the siege. Apply the forceps blades to the less accessible side of the tooth first under direct vision, and then apply the other blade. If one side of the tooth is destroyed by caries, the blade is applied to that side first and the initial extraction movement is toward that side as well. 1 apical grip. Seat as far down under gums towards bone as possible. Seat beaks parallel to long axis of tooth. Close handles and apply pressure to firmly grip tooth. Force should be applied with shoulder and upper arm and not with wrist. Apical pressure accomplishes 2 goals. The tooth socket is expanded by the insertion of the beaks down into the periodontal ligament space and causes bony expansion. A second accomplishment of apical pressure is to make the fulcrum more farther apically. 2 outward movement. Outward, labial or buccal movements is the first extraction movement for all maxillary and mandibular teeth, with the exception of mandibular third molar and to less extent the mandibular second molar, because of the presence of the external oblique ridge. 3 inward movement. Inward movement, lingual or palatal, is the second extraction movement of all teeth except of mandibular third molar and to less extent the mandibular second molar, where inward movement is usually the primary extraction movement. 4 rotation. It is applied after dilatation of the socket wall. Tooth becomes loose in the socket. It is used for tearing of the periodontal ligaments. Rotation may be used as the primary extraction movement in teeth with conically shaped roots, e.g., maxillary, central incisor and mandibular second premolar. 5 final movement, by which the tooth is completely removed from the socket by being delivered in bucco-occlusal direction, with combination of buccal and tractional forces. Careful final movement is indicated to avoid injury of the opposing teeth and slippage of the tooth from the forceps. Bone expansion. Expansion of the bony socket is achieved by using the tooth as a dilating instrument. Therefore, sufficient tooth mass must be firmly grasped by the forceps. The bone must be elastic enough to allow the expansion to occur. Thanks for watching. Support us, likes and subscribes.